ಮಧ್ಯೆ ಫ್ಲೋ ಸ್ಟಾರ್ಟ್ ಬ್ರೇಕ್ ಆದಂಗೆ ಆಗ್ಬಿಡುತ್ತೆ. ಅದು ಕಾನ್ಸಂಟ್ರೇಟ್ ಮಾಡ್ತಿರ್ತೀವಲ್ಲ ಅದನ್ನೇ ಹೇಳಬೇಕು ಕ್ಲಾಸ್ ಎಲ್ಲ.
The last class I told about the Hodgkin's lymphoma. In that I think I have told you the clinical aspects of this Hodgkin's lymphoma. And also the important cell that is present in Hodgkin's lymphoma is Dorothy Reed-Stein Bcell, which is a must for the diagnosis of this Hodgkin's lymphoma. Right. There are, according to the classification, according to Rice classification, we classify Hodgkin's lymphoma into lymphocytic predominant type, and then nodular sclerosis type, mixed cellular type, and lymphocytic depletion type. But according to the WHO classification, Hodgkin's lymphoma has been classified into classical and non-classical type. In the classical type, it is lymphocytic rich type, and then mixed cellular type, and then the nodular sclerosis type and lymphocytic depletion type. Classical type, that is lymphocytic predominant type. These two differentiate by the clonal densities that is present on the surface of the cells. In case of the classical type, CD15 and CD30 is positive. Whereas in a lymphocytic predominant type, it is CD45 and CD20 which is positive. CD45 and then epithelial membrane antigen is also positive in case of lymphocytic predominant type. So that is that's where I have stopped at the last class. Coming to the gross pathology of this Hodgkin's lymphoma. Grossly, this Hodgkin's lymphoma, as I told them, the lymph node involvement may be confined to the single anatomical site, or next is adjacent anatomical site, and then either side of the diaphragm, and along with that there may be involvement of the spleen, that is extra lymphatic organ, or the splenic involvement may be seen. And these lymph nodes are discrete in nature. They are discrete in nature. That means the boundary of one lymph node, it can be definitely separated from the another lymph node. That is the meaning of the discrete lymphadenopathy, which is very characteristically seen in not only in Hodgkin's lymphoma, even in non-Hodgkin's lymphoma also. But these lymph nodes in the later stages, if there is infiltration into the pericapsular region, lymphoma cell infiltration, then there may be matting of one lymph node with the another lymph node. And these lymph nodes are discrete and rubbery in consistency. That is, they call it as India rubbery consistency. India rubbery consistency is very characteristically seen in cases of lymphoma, not only in Hodgkin's lymphoma, even in cases of non-Hodgkin's lymphoma also, they are India rubbery in consistency in the initial stages. And these lymph nodes are of varying size. The size of these lymph nodes may be varying. Some may be smaller, some may be medium size, some may be larger in size. Right, that is the gross appearance. They are India rubbery consistency, discrete in nature, and and they are of varying in size. Cut section, it is showing, they show a homogeneous grayish white, like that of the flesh of the fish. That is a fish flesh appearance, very characteristically seen in case of this lymphoma. Not only in Hodgkin's lymphoma, even in non-Hodgkin's lymphoma also, that fish flesh appearance is seen. And in cases of this nodular sclerosis type of Hodgkin's lymphoma, we see broad bands of fibrosis separating this lymph node into separate nodules. Nodularity is seen, and these nodules are separated by fibrocollagenous tissue septa in case of nodular sclerosis type. Otherwise, it is homogeneous grayish white or fish flesh appearance. Whereas in case of a lymphocytic depletion type, there are two types in that, a reticular type and fibrillar type. So there will be fibrillar material, or the collagen, broad bands of collagen can be seen in case of the lymphocytic depletion type. There will be paucity of the lymphocyte. There will be areas of necrosis is seen in case of lymphocytic depletion type. So this is the gross feature that we see in case of this Hodgkin's lymphoma. coming to the microscopy, microscopically, as I told, it is Dorothy Reed Steinberg cell, which is very characteristically seen in case of this Hodgkin's lymphoma. Now, coming to the first one, that is lymphocytic rich type. Lymphocytic rich type, it accounts for the lesser percentage of this Hodgkin's lymphoma. It may account for about 5%, uncommon, and the prognosis is very excellent in case of this lymphocytic rich type. And it may be associated with this Epstein-Barr virus. Epstein-Barr virus may be an association in case of this lymphocytic rich type. It is an uncommon type of Hodgkin's lymphoma. And here, in case of this lymphocytic, it may be nodular or it may be diffuse. So nodular type, which is more commonly seen, where there will be lymphocytic proliferation. So the architecture of the lymph node, architecture is effaced. Architecture of these lymph nodes are effaced. Architecture means the lymph node should have a cortex, and in the cortex follicles, parafollicular area, and then the medulla. So that is the meaning of the normal architecture. So here the architecture of the lymph node is completely effaced. So once there is effacement of this architecture, then we see the small lymphocytes are seen. Small lymphocytes are seen. There will be lymphocytic proliferation. These small lymphocytes, they show the nodularity. So there will be proliferation of this small lymphocytes, lymphocytic proliferation, which may form vague nodularity. Vague nodularity is seen. Along with this lymphocytic proliferation, we may see few histiocytes, larger cells, histiocytes. So it is mainly the lymphocytes which are predominantly seen. Along with that, we may see a few histiocytes, and it is very difficult to find the RS cells. But we have to search for this RS cells. The RS cells are a classical type of RS cells are seen. Classical type of RS cells are seen. This I think I have told you how this classical RS cells will be seen. So classical RS cells and even the polyploidal RS cells can be seen. So it is classical RS cells and the polyploid. There will be paucity. There will be decrease in the less number of RS cells, but these RS cells may be classical RS cell or a polyploidal or popcorn type of RS cells are seen in case of this lymphocytic rich type of Hodgkin's lymphoma. So in this lymph node, architecture is completely effaced and it will be replaced by a sea of small lymphocytic proliferation with a few histiocytes. And these lymphocytes may show a nodularity, a vague nodularity, and these RS cells are less in number. We have to search for a longer period to find these RS cells, which may be classical RS cells or it may be polyploidal RS cells that are seen in case of this lymphocytic rich type of Hodgkin's lymphoma. The commonest type of Hodgkin's lymphoma that we see is nodular sclerosis. Nodular sclerosis type is the commonest type and it is more commonly seen in males. And this accounts for about 40% or more than 40% of this Hodgkin's lymphoma. Nodular sclerosis is the commonest type of Hodgkin's lymphoma that we see, nodular sclerosis type. So here the lymphadenopathy, this also the, as I told, presents with lymphadenopathy, etc. And here the lymph nodes shows nodularity. The lymph nodes show nodularity, and this accounts for about 40% of this Hodgkin's lymphoma. And these nodules are separated by the fibrocollagenous tissue septae. These nodules are separated by broad bands of fibrocollagenous tissue septae, and in the individual nodules we see mixed cell population. mixed cell population are seen in the individual nodules. What mixed cells? It is lymphocytes, and then the eosinophils, and then the histiocytes. Lymphocytes, histiocytes, and then the eosinophils are also seen. Mixed cell population are seen in the individual nodules. Then what type of RS cells that we see in case of nodular sclerosis? It is the lacunar type of Dorothy-Reed-Steinberg cell. Lacunar type of Dorothy-Reed-Steinberg cells are seen in case of a nodular sclerosis type of Hodgkin's lymphoma. This has got a good prognosis when compared to the other types, right? This accounts for about 40%. So here also the architecture of the lymph node is effaced, and the entire lymph node is replaced by the nodules separated by broad bands of fibrocollagenous tissue septae, and the individual nodules shows mixed cell population consisting of lymphocytes, histiocytes, and then eosinophils and few neutrophils also. There may be some amount of areas of necrosis can be seen in this nodular sclerosis type of, right? Along with that, the important cell, that is the lacunar type of Dorothy-Reed-Steinberg cell are seen in this nodular sclerosis type of Hodgkin's lymphoma. Coming to the next one, that is the mixed cellular type. Mixed cellular type also accounts for lesser percentage of Hodgkin's lymphoma. Mixed cellular type. Mixed cellular type. So here mixed cellular type, here the lymph node architecture as usual, it is obliterated, and there will be thickening up of the capsule, and the entire lymph node is replaced by mixed cell population. Mixed cell population of cells are seen, that is lymphocytes, histiocytes, eosinophils, etc. are seen in the lymph node. Along with that, a classical type, along with this classical type of that is owl's eye appearance, classical type of Dorothy-Reed-Steinberg cells are seen, and here it is diffuse in pattern. Diffuse in pattern. This accounts for the lesser percentage. This also has got some amount of good prognosis only. That is a mixed cellular type. Coming to the next one, that is a lymphocytic depletion type. Lymphocytic depletion type, that is the that has got a worst prognosis. Lymphocytic depletion type. Lymphocytic depletion type. Usually this is associated with the HIV infection. This is usually associated with the HTLV virus infection, and also Epstein, even the viral infection may be an association in this lymphocytic depletion, and this usually occurs in the older age group. This usually occurs in the older age group. This may be associated with human immunodeficiency virus, even the EB virus association is seen in case of this lymphocytic depletion type. And here the lymph nodes will show large areas of necrosis. Necrosis is seen in this, and there will be extranodal involvement like spleen, liver involvement is also splenic, and liver involvement may be may be seen in this lymphocytic depletion. So this has got a worst prognosis. The prognosis is worst in case of this lymphocytic depletion. This accounts for a lesser percentage of this Hodgkin's lymphoma. Lesser percentage of Hodgkin's lymphoma is accounted by this lymphocytic depletion type. So what are all the microscopic features? This has got two types. One is fibrillar type, and the second one is reticular type. In case of fibrillar type, there will be large amount of fibrillar collagen material in the lymph node. Along with that, there will be hyaline-like eosinophilic material, and in that eosinophilic material, we see mixed cell population. Mixed cell population. Along with that, there will be pleomorphic or anaplastic anaplastic or pleomorphic RS cells are seen. So the type of RS cells is pleomorphic or anaplastic RS cells are seen. Along with that, there will be mixed cell population, and there will be collagenous fibrillar collagenous material is seen. There will be paucity of the cells. Cells are lesser in number in case of a fibrillar. Whereas reticular type of lymphocytic depletion, there will be reticulin material. Along with that, some amount of good cell population when compared to the fibrillar type. So there will be mixed cell population with the anaplastic RS cells. Anaplastic type of are the pleomorphic RS cells. Some may be larger, some may be smaller, some are of medium size, some may contain more than 1 to 2 nucleoli. Some may contain 3, like that. So pleomorphic type of RS cells or the anaplastic RS cells are seen, and there will be areas of necrosis also seen in case of this lymphocytic depletion. It is worst, it has got a worst prognosis when compared to the other types of lymphomas, Hodgkin's lymphomas. Coming to the next one, that is I think I told you the prognosis, that is the gross and microscopic pathology of this Hodgkin's lymphoma. Coming to the other laboratory investigations, what other laboratory investigations which can support this Hodgkin's lymphoma are other added features. So because there is infiltration into the bone marrow by this Hodgkin's lymphoma cells, so there will be normocytic normochromic anemia, and there will be ferritin level will be decreased, and then there will be increase in this total iron binding capacity. Total iron binding capacity is increased, ferritin level is decreased, and because there is infiltration into the marrow, there will be release of immature cells of the RBCs and WBCs into the peripheral blood, resulting in leukoerythroblastic reaction. So where there will be immature cells of the RBCs like normoblasts, etc., plus the immature cells of the WBCs, that is promyelocytes, myelocytes, etc., will be present in the peripheral blood. So that we call it as leukoerythroblastic reaction. And there will be peripheral eosinophilia. Eosinophils are increased in number. Absolute eosinophil count. What is the normal absolute eosinophil count? It is 40 to 400 cells per cubic millimeter. So there will be eosinophilia. Peripheral eosinophilia is also one of the laboratory findings that we see in case of the Hodgkin's lymphoma. And then the ESR, that is erythrocyte sedimentation rate, is also increased in case of this Hodgkin's lymphoma, right? So these are other laboratory findings that we see in case of Hodgkin's lymphoma. ESR is increased, and then the eosinophilia, leukoerythroblastic reaction, and then the eosinophilia, normocytic normochromic anemia. That is about the other laboratory investigations that we see that we can go for in cases of this Hodgkin's lymphoma. One more finding, so this can involve the bones, that is the spine, etc. In that it produces osteosclerotic lesion. Osteosclerotic lesion, not an osteolytic. It produces osteosclerotic lesion in the vertebra. Vertebral involvement is also seen. So that is about the Hodgkin's lymphoma, gross pathology and microscopy. So they may ask you the RS cell as a short note question, that is Dorothy Reed-Steinberg cell as a short note question, and then the Rice classification or classification, microscopic classification of Hodgkin's lymphoma, or they may ask it as pathology of Hodgkin's lymphoma. Next question that can be asked on this Hodgkin's lymphoma is the staging of Hodgkin's lymphoma. That staging we call it as Ann Arbor staging. Ann Arbor staging. This is done in Michigan, where they have staged this Hodgkin's lymphoma into 4 stages. That is stage 1, 2, and then 3, and then 4. So these are the 4 stages that has been done in this Michigan, that is Ann Arbor's staging. So this is helpful for the prognosis and also for the treatment wise. For the treatment, where they can do the staging, laparotomy, etc. So that is, staging can be done. Staging is helpful for the treatment aspect and also for the prognosis. So this is according to this anarcho staging, Hodgkin's lymphoma into 4 stages, stage 1, 2, 3, 4, right? And this has got an additional suffix A bar B. A means absence of symptoms, except for the lymphadenopathy, no other prodromal symptoms. B is, along with the lymphadenopathy, there are prodromal symptoms like anorexia, fever. This fever is a Pell-Epstein type of fever, very characteristically seen in case of this Hodgkin. What do you mean by this? Pell-Epstein fever. So, so many days the patient will have fever. Then there is disappearance of the fever. Again, a reappearance of the fever. This is a Pell-Epstein type of fever, which is seen in case of this Hodgkin's lymphoma. Right? So absence of symptoms, only lymphadenopathy. B is presence of symptoms along with the lymphadenopathy. In all these stages, this A and B is added up, right? So stage 2A means there will be lymphadenopathy without the symptoms. Lymphadenopathy with symptoms, that is 2B. Now what is stage 1? Stage 1, involvement of a single anatomical group of lymph nodes. Involvement of single anatomical group of lymph nodes. That is confined to the cervical lymph node, confined to the supraclavicular, right? So single anatomical group of lymph nodes are involved in stage 1. Whereas stage 1E, that is the involvement of this extra lymph node, extra nodal involvement, that is stage 1E. Whereas stage 2, here the adjacent anatomical group of lymph nodes are involved. For example, cervical group. Adjacent to that is axillary. So adjacent anatomical group of lymph nodes are involved, but it is confined to a single side of the diaphragm. So confined to the cervical and axillary, not on the opposite side of the diaphragm. That is stage 2. Right. Along with that, there is stage 2E, that is the localized or generalized involvement of this extra lymph node. Adjacent two organs are involved, but it is also confined to a single side of the diaphragm. Stage 2E. Whereas stage 3 is the involvement of the anatomical group of lymph nodes on either side of the diaphragm. So there will be involvement of the cervical, axillary, inguinal. So on either side of the diaphragm there will be involvement of the lymph nodes. That is stage 3. In that stage 3E, that is there will be adjacent anatomical group of organs other than the lymph, that is the extra nodal involvement. If there is involvement of 3S, that is splenomegaly, where there will be diffuse involvement of the spleen or a localized involvement of the spleen, that is 3S. If there is combination of this extra lymphatic organ along with the involvement of the spleen, then that is stage 3ES. So here stage 3 is involvement of an anatomical group of lymph nodes on either side of the diaphragm. If it is 3E, that is more than one organ, there will be diffuse or localized involvement of the organ involvement. Whereas only spleen is involved, then 3S. If combination of this extra lymphatic organ plus the splenic involvement, then stage 3ES. So that is stage 3. Whereas stage 4, that is a diffuse involvement, disseminated involvement of the extra lymphatic organ with or without the lymph node involvement. So disseminated, almost all are involved. along with the lymphadenopathy or without lymphadenopathy, with or without lymphadenopathy. So this is the 4 disseminated. This has got a worse prognosis if it is stage 4. So an adverse staging of lymphoma is stage 1, 2, 3, 4. 1, it is confined to a single anatomical site. 2, it is adjacent anatomical site and confined to a single side of the diaphragm. Stage 3, on either side of the diaphragm. And stage 4, there will be disseminated involvement of the lymph nodes and even the other organs also. In that there is special variety 1E, 1, 2E, that is extra lymph nodal, extra nodal involvement. Right, and then thus S if there is involvement of the spleen. Combination of this extranodal involvement along with the spleen involvement, that is 3ES. Disseminated, that is stage 4. So this is an adverse staging of lymphoma. Some people say even this is applicable even for the non-Hodgkin's lymphoma also, right? So this is a short note question. An adverse staging of Hodgkin's lymphoma. So that is about the Hodgkin's lymphoma. Coming to the non-Hodgkin's lymphoma. Coming to the non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma. So there will be proliferation of the lymphocytes, that is T cell, B cell, and also the histiocytic proliferation, that is which has been classified depending upon the architecture, that is maybe nodal. So that means there will be follicular arrangement or there may be diffuse involvement. So depending on that and the cell type that is involved, that is called Rappaport's classification. It's a morphological classification. It lacks the type of cell, whether it is T cell or B cell. So that is Rappaport's classification, purely depending upon the architecture, that is a nodular or a diffuse type. That is Rappaport's classification. Later on, depending on the type of cell, whether it is B cell or T cell, that is Luke's and Collin's classification. Luke's and Collin classification. Still later, that is Keel's classification. Keel's classification, they have incorporated the different types of cells plus the arrangement of the cells. That is Keel's classification. And later on, there is a WHO classification. That is a low grade, intermediate grade, and a high grade. That is working formulation. Working formulation, low grade, intermediate grade. That is depending on the survival rate. Low grade, 5-year survival rate, 60 to 70%. Intermediate grade, 5-year survival rate, 35 to 40%. And then high grade, that is less than around 10%, 5 to 10% 5-year survival rate, that is a high grade. So that is a working formulation. That is also not practiced. So important is WHO classification of non-Hodgkin's lymphoma, which has been broadly classified into T cell and B cell. That is a precursor B cell, and then peripheral B cell type. Precursor B cell and then peripheral B cell type, and then precursor T cell type, precursor T cell type, and then peripheral T cell type, peripheral T cell type. So these are the broader classification, WHO classification of this non-Hodgkin's lymphoma. Precursor B cell and then precursor T cell. These two is similar to that of that is acute lymphoblastic leukemia or lymphoma. Acute lymphoblast. This I think we have covered in the leukemia chapter, right? The peripheral B cell and then peripheral T cell. What is the different types of non-Hodgkin's lymphoma which comes under peripheral B cell. Peripheral B cell, mainly I told in the lymph node architecture, it involves only B cells, means it is the follicular. So these lymphomas may have the follicular arrangement, that where they include the cleaved cell and then small cleaved, large cleaved, small non-cleaved, and then large non-cleaved. That is follicular center cells, where they will show the follicular arrangement of the lymph nodes, that is lymphocytes. That is a follicular lymphoma. Follicular lymphoma is one of the non-Hodgkin's lymphoma which comes under peripheral T-cell lymphoma. Right. Now, from the germinal centers, there will be increased proliferation of this large B cell that is known as diffuse large B cell lymphoma. Diffuse large B cell lymphoma, that is the second one. So, which arises from the germinal center or post-germinal center. Germinal cell from the germinal center or post-germinal center, that is diffuse large B cell lymphoma. Whereas the follicular center cells forming the nodules, that is follicular lymphoma. Follicular lymphoma. Some of the cells, some of the lymphomas arises from the marginal zone cells. That is known as marginal zone lymphoma. Marginal cell or marginal zone lymphoma. Marginal zone cell lymphoma. Some of these lymphomas arises from the mantle cells. Mantle area, the cells in the mantle area, that is called mantle cell lymphoma. Mantle cell lymphoma, that is also one of the peripheral B cell lymphoma. Right. So, follicular lymphoma, marginal zone lymphoma, and then diffuse large B cell lymphoma, where it arises from the larger cells in the germinal center or post-germinal center. And then the cells in the mantle zone can also give rise to lymphoma, that is known as mantle cell lymphoma. Some of the lymphomas arises from the nave cells, that is small lymphocytic lymphoma. SLL, small lymphocytic lymphoma, that is from the nave cells. So, this is SLL bar CLL. Chronic lymphocytic leukemia bar small lymphocytic lymphoma, right? Small naive cells. Naive cells can give rise to the small lymphocytic lymphoma. Some of these can give this lymphocytes. First, it will be lymphoblast, which matures into the pro-lymphocyte and then to the lymphocyte. Some of these pro-lymphocytes can also give rise to lymphoma, that is the pro-lymphocytic lymphoma. Pro-lymphocytic lymphoma, and some of these base cells may have this peripheral projection, hairy-like projection, that is a hairy cell lymphoma. Hairy cell lymphoma, so which is also a peripheral B cell type of lymphoma, and this gives rise to the plasma cells. So, plasma cells can also give rise to lymphoma, that is a multiple myeloma. Multiple myeloma. So, and then these lymphocytes which are present even in the extranodal, in that also the extranodal marginal zone lymphoma. Extranodal marginal zone lymphoma. So, here this is nodal marginal zone lymphoma, this is extranodal marginal zone lymphoma. So, these are the various types of peripheral B cell lymphoma. In that, the small lymphocytic lymphoma SLL bar CLL, then the follicular lymphoma, then the diffuse large B cell lymphoma, then the marginal zone lymphoma, which is nodal, and there is extranodal marginal zone lymphoma, and a pro-lymphocytic type of lymphoma, and then airy cell lymphoma, and then the mantle cell lymphoma, and then the multiple myeloma. So, these are the various types of peripheral B cell lymphoma. Clear? Now, the next one is peripheral T cell lymphoma. So, that is a precursor and the peripheral. Precursor T cell lymphoma similar to that leukemia, right? So, here the peripheral T cell lymphoma, which has been classified into three types. One is nodal, and then the extranodal, that is the second one, extranodal, and then the cutaneous, and then the extranodal, nodal, cutaneous, and the fourth type along with the cutaneous type, there is fourth type, that is leukemia-like picture. leukemia like type of non-Hodgkin, T-cell non-Hodgkin's lymphoma. In the nodal, that is a peripheral T-cell lymphoma. Peripheral T-cell lymphoma, not otherwise specified. Peripheral T-cell lymphoma. Then angioimmunoblastic T-cell lymphoma. Angioimmunoblastic T-cell lymphoma. And then anaplastic large cell lymphoma. Anaplastic large cell lymphoma. Anaplastic large cell T-cell lymphoma. And then in the extranodal, it involves T-bar NK cell lymphoma. T-bar NK cell lymphoma, that is extranodal. And then the hepatosplenic type of non-Hodgkin's T-cell lymphoma, hepatosplenic type. And then T-bar NK cell lymphoma. And then the cutaneous type. In the cutaneous type, the Cesare syndrome. In the earlier this one, peripheral T-cell lymphoma, small cleaved cells can also give rise to lymphoma, that is called Burkitt's lymphoma. I think I forgot to mention that. So Burkitt's lymphoma, which also comes under non-Hodgkin's lymphoma Bcell type, right? So here the cutaneous Cesare syndrome. And then mycosis fungoides, and then Cesare syndrome. Whereas leukemia-like picture, that is the prolymphocytic T-cell lymphoma, then adult T-cell leukemia bar lymphoma, and then so this is ATL, leukemia bar lymphoma. And then prolymphocytic type of leukemia, and even the CLL T-cell type can also be seen. Right? So these are the different types of T-cell lymphoma. One is nodal, that is angioimmunoblastic T-cell lymphoma, peripheral T-cell lymphoma, not otherwise specified. Anaplastic large T-cell lymphoma. In the extranodal, hepatosplenic type, and then T-bar NK cell type of non-Hodgkin lymphoma. And the cutaneous Cesare syndrome, mycosis fungoides, and then leukemia like, that is adult T-cell leukemia bar lymphoma, and a prolymphocytic T-cell type of lymphoma. All this comes under the peripheral T-cell lymphoma. So sometimes they may ask this as a classification. Classify the non-Hodgkin's lymphoma. I think very rarely they will ask. So it is very difficult to remember for you also. So only the different types of lymphoma, non-Hodgkin's lymphoma. In that term, the commonest one is diffuse large B-cell lymphoma. It can be asked as a short note question. And then Burkitt's lymphoma can also be a short note question. Follicular lymphoma is also a short note question. That is follicular lymphoma, and that is a short note question. And then Burkitt's lymphoma is a short note question. And then diffuse large B-cell lymphoma is a short note question. Mycosis fungoides is also a short note question. These are the 5 short note questions that you can expect in case of non-Hodgkin's lymphoma. Coming to the etiology, what is the cause for this the non-Hodgkin's lymphoma, or in general the lymphoma? What is the cause for this? The causes for this lymphoma are maybe due to the genetic abnormalities. Genetic abnormalities may be one of the cause. For example, the translocation of this chromosome 14 to 18 or 8 to 14 translocation, and 14 to 18 genetic involvement. Maybe the genetic involvement may be one, and these lymphomas are associated with genetic abnormalities like Down syndrome, etc. So genetic abnormalities may be one of the cause for this lymphomas. And the second one, the viral etiology. That is, some of the lymphomas, for example, this that Hodgkin's lymphoma is associated with this Epstein-Barr virus. See, even the Burkitt's lymphoma, which is a non-Hodgkin's lymphoma, may be associated with this Epstein-Barr virus. And this HTLV virus, human T-cell leukemia virus, is also one of the viral etiology for the lymphomas, mainly the non-Hodgkin's lymphoma HTLV virus. And the HHV virus, herpes virus number 8, is also one of the viruses which can give rise to the lymphoma. HHV virus, human herpes virus. That is, and then hepatitis C virus. Hepatitis C virus can also give rise to the lymphoma. And some of the bacterial, that is H. pylori. H. pylori infection can give rise to gastric lymphoma, lymphoma of the gastrointestinal tract, right? So viruses, first is genetic, next is viruses is also one of the etiological causes for this. Exact etiology is not known because all lymphomas may not show the Epstein-Barr virus, right? Like that. So genetic abnormalities is, these are all the probable theories that has been put forward for the lymphomas to occur. One is genetic causes, next is viral etiology, and the third is the immunosuppression. Immunosuppression is also one of the cause for the development of this lymphoma. For example, in case of organ transplantation, lymphomas are more commonly seen. And the people with immunomodulant drugs, there will be chances of getting a lymphomas. Immunosuppression, organ transplantation, and even the HIV infection. Lymphomas may be associated with this HIV infection. Not only lymphoma, even other malignancies are also seen in case of this HIV infection. For example, this Kaposi sarcomas, etc., can be seen in immunosuppressed individuals. Organ transplantation and immunomodulant therapies, etc., can give rise to this lymphomas. And some of the radiotherapy, for some carcinomas the patient will be receiving the radiotherapy, so that can give rise to the lymphomas. Radiological exposure can give rise to these lymphomas. And some of the autoimmune diseases, may be associated with this lymphoma, like SLE, etc., can be associated with this lymphoma. So these are the probable etiologies that has been put forward for the causation of this lymphoma. One is genetic abnormality, and then immunosuppression, radiotherapy, autoimmune diseases, and the viral infection and some of the bacterial infection can cause the lymphomas. That is about the etiology of this lymphomas. Coming to the first one, that is follicular lymphomas. Follicular lymphoma, it is usually seen in the younger individuals, that is around 30 to 40 years. Younger individuals, it runs an indolent course. So this follicular lymphoma, it occurs in the younger individuals. It occurs equally in both the sexes, right? And younger individuals, waxing and waning are the indolent course. It runs an indolent course. Sometimes there will be larger in size in the lymph node. Sometimes there will be decrease in the size of the lymph nodes. Waxing and waning, that is very characteristically seen in the follicular lymphomas. Younger individuals, equal distribution, and the commonest lymph nodes involved are the cervical, supraclavicular, axillary lymph nodes. Generalized lymphadenopathy is one of the clinical presentation that we see in case of a follicular lymphoma. Along with this, the patient may have the anemic signs and symptoms. Loss of weight, loss of appetite, plus the anemic signs and symptoms, because there will be infiltration of these lymphoma cells into the bone marrow. So because there is infiltration into the bone marrow, so naturally the patient will have the anemic signs and symptoms. Plus there will be decrease in the number of functioning leukocytes. The patient may have the repeated infections, and there will be involvement of this spleen and liver. So there will be infiltration of these lymphoma cells into the bone marrow in the paratrabecular region, and in the liver, it is the portal triad. There will be infiltration of these lymphoma cells, thus resulting in the enlargement of the liver. And even the splenic white pulp, there will be infiltration of these lymphoma cells resulting in splenomegaly. So the patient will have hepatosplenomegaly, generalized lymphadenopathy, plus the anemic signs and symptoms because of the involvement of the bone marrow. About 90% of these individuals will have the bone marrow infiltration, right? And this can go into in the later stages can go into diffuse large B-cell lymphoma. And this accounts for about 22% of this non-Hodgkin's lymphoma. This follicular lymphoma accounts for about 22% of this non-Hodgkin's lymphoma. So it is the indolent, it runs an indolent course, and younger individuals, that is between 30 to 40 years, that is the age of occurrence, equal in both sexes. And here the translocation between 14 to 18 chromosome is known in some of the individuals. Translocation of this Ig gene which leads on to, this is MM2. That is the one where there will be epigenetic mechanism is activated. It is MM2. That is epigenetic mechanism, sorry, MLL2, sorry, it is MLL2 gene which is involved in this. So this acts by this epigenetic mechanism where there will be proliferation of this follicular center cells resulting in a lymphoma. So epigenetic mechanism is involved. So there will be translocation of this chromosome 14 to 18. And this occurs in younger individuals, and it runs an indolent course where there will be waxing and waning. Plus the patient will have lymphadenopathy, hepatosplenomegaly. Since there is bone marrow infiltration, the patient will have the anemic signs and symptoms. And these lymph nodes are, it is applicable for the other types of lymphoma. That is, there will be, these lymph nodes are of varying size, they are forming consistency, and they are discrete in nature. But later on there may be matting in the later stages, right? So that is the gross and the microscopic features that we see in cases of this follicular lymphoma. Coming to the microscopy, microscopically the lymph node architecture is completely effaced. Lymph node architecture is completely effaced. The lymph node is replaced by the lymphoid follicles which are present both in the cortex and in the medulla. So both cortex and medulla will show the follicles, and these follicles are of uniform in size, monomorphic. All follicles looks alike, both that is size wise and also morphological size and shape wise. And they are lacking in germinal centers. So they are present both in the cortex and in the medulla, and they show the two types of cells. One is a centroblast and centrocytes, that is cleaved cells and the non-cleaved cells. Cleaved and non-cleaved cells are seen. So there are no germinal centers, they are of monomorphic, follicles are monomorphic, and no germinal centers are seen, and the mitotic divisions are also not seen, mitotic divisions are not seen, no germinal centers, monomorphic follicles, and polarity is also altered, maintained, right? And the stingible body macrophages are absent. And surrounding the individual follicles, there is a clear space, clear demarcation of the follicles is seen in this follicular lymphoma. So this has to be differentiated from the follicular reactive hyperplasia. So this, I think I have told you in the last class how to differentiate follicular reactive hyperplasia from the follicular lymphoma. So here the follicles are of monomorphic in size, they are distributed both in the cortex and in the medulla, and individual follicles, there is a clear demarcation of the individual follicles, and the polarity is maintained, and these consisting of cleaved cell and the large, that is centrocyte centrocytes and centroblasts are seen. Maybe predominantly centrocytes or combination of centrocytes and centroblasts are the only the centroblasts, right? And there are no germinal centers. No germinal centers. If you see the germinal centers with tingible body macrophages, then it is a reactive hyperplasia, right? And then these are associated with this Bcell2. Bcell2 abnormality is Bcell2 is present in this cases of this follicular lymphoma, but not so in case of follicular reactive hyperplasia. So this is the microscopic picture that we see in case of a follicular lymphoma. So this is a short note question. So age of occurrence, causes, gross appearance, microscopy, and then the clinical features. If you want, you can write. Otherwise, only the pathological aspects you are supposed to write. So it is one of the lymphoma which accounts for about 22% of the non-Hodgkin's lymphoma. It usually occurs in adults. Males and females are equally affected. And generalized lymphadenopathy, waxing and waning and indolent courses, and then the gross and microscopy you are supposed to write if they ask this as a short note question. And how to differentiate, if you find time, you can write how to differentiate follicular lymphoma from follicular reactive hyperplasia, right? Coming to the next one, that is diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma. This is one of the commonest type of non-Hodgkin's lymphoma. This accounts for about 70% of this non-Hodgkin's lymphoma. And here, this is usually associated with the Bcl6. This is associated with the Bcl6. Bcl6. And it is the diffuse type. Diffuse type, Bcl6 is association, and this is more commonly seen in males. So increased incidence of this diffuse large B-cell lymphoma is seen in males and compared to the females. And this can involve, that is a generalized lymphadenopathy is one of the commonest. Along with there will be involvement of this spleen and liver. So there is diffuse organ involvement. Hepatosplenomegaly is also one of the features that we see in case of the diffuse large B-cell lymphoma. This can also involve the extranodal site. Extranodal site, GIT can be involved. GIT, and then skin is involved. That is gastrointestinal tract, and then skin involvement, and then the brain involvement. Brain involvement is seen in case of this diffuse large B-cell lymphoma. So hepatosplenomegaly, involvement of the skin, involvement of the GIT, that is gastrointestinal tract, and the brain involvement is seen in case of a diffuse large B-cell lymphoma. So lymphadenopathy, along with the lymphadenopathy, the patient will have the other clinical signs and symptoms like anemia, loss of weight, loss of appetite, etc. will be seen. So generalized lymphadenopathy plus involvement of this the extranodal involvement, that is GIT, skin, and even oropharynx involvement can also be seen. Tonsillar involvement can also be seen in this diffuse large B-cell lymphoma, and this occurs in older individuals. Older individuals, that is around 60 or more than 60 years of age of occurrence of this diffuse large B-cell lymphoma, right? Along with that, so here Bcl6 and then organ involvement, that is clinical features of this diffuse large B-cell lymphoma. And this is associated with Bcl6, I have told, dysregulation of this Bcl6, and even translocation is also noticed in this. 14 to 18 translocation is also notified in this diffuse large B-cell lymphoma. This is for two types. One is this is for two types. One is the immunodeficiency. Immunodeficiency associated. One is associated with this immunodeficiency association 1. Then the next one is effusion. That is primary effusion. Primary effusion. that is ascites, primary effusion, that is ascites or pleural effusion. Pleural effusion associated, immunodeficiency associated or primary effusion. Maybe ascites, that is accumulation of fluid in the abdominal cavity. Ascites or accumulation of the fluid in the pleural cavity, that is pleural effusion. Effusion associated, immunodeficiency associated. And there may be involvement of this mediastinal group of lymph nodes. In this diffuse large B-cell lymphoma, there may be involvement of this mediastinal group of lymph nodes also. Coming to them, grossly, the lymph nodes are of varying size. They are discrete and as applicable to other types of lymphomas also. Coming to the microscopy. So, coming to the cell of origin, it arises from the larger cells of the germinal center or the post-germinal center. Larger cells of the germinal center or the post-germinal centers, and there will be effacement of this architecture. Effacement of this architecture of the lymph node. So, no this one cortex, no medulla. So, entire lymph node is replaced by the cells which are about 2 to 3 times the size of the small lymphocyte. 2 to 3 times the size of the small lymphocyte. And these cells will show margination of the chromatin. So, these cells show margination of the chromatin. So, chromatin is marginated towards the nuclear boundary. And we see the nucleoli, about 2 to 3 nucleoli towards the marginized chromatin, that is towards the nuclear periphery. We see 2 to 3 nucleoli, nucleoli which are placed towards the nuclear boundary. And the cytoplasm is moderate in amount. Cytoplasm is moderate to even a larger amount of cytoplasm, right? So here the cells are about 2 to 3 times the size of the lymphocyte, that is a larger cells as the name tells, diffuse large B-cell lymphoma. So diffuse involvement of the lymph node, and these cells are about 2 to 3 times the size of the lymphocyte, and they show the nucleus which is vesicular nucleus. Why it is vesicular? Because the margination of the nuclear chromatin towards the nuclear boundary. And there are 2 to 3 nucleoli which are placed towards the nuclear boundary. And some of these cells may show a single nucleoli which is a larger nucleoli which is placed exactly in the center. So there are 2 to 3 nucleoli which are placed away, that is towards the margin of the nucleus, or a single nucleoli which is present in the center of the nucleus. So this type of cells are diffusely seen in entire lymph node is replaced by this type of cells. So larger cells seen in sheets, they are seen in sheets, and cytoplasm is abundant, right? So this is about the microscopic feature of this diffuse large B-cell lymphoma. With radiotherapy and chemotherapy, the patient may become the prognosis. Patient may improve with the radiotherapy and chemotherapy. That is about diffuse large B-cell lymphoma. I think in the next class, let me tell you about the Burkitt's lymphoma, and then mycosis fungoides, and then the spleen. That will complete the portion, right, of lymphoreticular system. So this is about the classification of the non-Hodgkin's lymphoma, and then diffuse large B-cell lymphoma, follicular lymphoma, which is a short note question. One more short note question is Burkitt's lymphoma, that I think I will cover it in the next class. Thank you very much.